Okay, now time to introduce our speaker today. We are thrilled to have Dr. Comtois come speak for us today. Dr. Comtois is a PhD clinical psychologist at the University of Washington Medical Center Outpatient Psychiatry Clinic. She is a professor at the University of Washington Department of Psychiatry and researcher who has been working with suicidal and highly emotionally distressed patients for more than 30 years. In addition to providing clinical work herself, she is trained and director of the Suicide Care Research Center in the Center for Suicide Prevention and Recovery, whose goals are to improve support for staff as well as suicidal patients and families. So with that, I'm going to exit stage left and turn it over to our speaker today.
Thank you so much to Brad and the Behavioral Health Institute and everybody who's been bringing this series
You
together.
may be muted, Dr. Comtois. We're not hearing you.
I'm not muted.
No,
So
I'm hearing her.
are you?
I'm hearing you, Kate.
Okay.
Yeah.
I'll go for it, but tell me if I should pause.
Okay.
So what I'd like to do today is to talk a little bit about how we think about suicide risk assessment and management in our virtual telehealth mental health world these days. So much of it pivoted with the COVID pandemic and then never returned to in-person work. Some things are slowly returning, some things are not. But I think it continues to be worth thinking about what does it mean to do care with suicidal individuals when you're not physically with them. Before I start, I just wanted to highlight, as Brad says, I work with two centers, the Center for Suicide Prevention and Recovery and the Suicide Care Research Center. One of the projects that CSPAR has done is to develop resources for clinicians who have survived the loss of a patient who died by suicide. And I think Carl will put it in the link to that page on our website, or you can just go to CSPAR in Google. It'll almost always find you there. And this is on the resource page. But I just want to call that out because I know this is a topic that can be challenging for some people. So just to make sure you know those resources are there. So I've done a fair amount of work with the active duty military and trying to reduce suicide in that world. And they've got wonderful acronyms. It's one thing I kind of learned from them. And BLUF, or bottom line up front, is a really common concept, and I think it really applies in this situation. So I'm just gonna kind of give you my bottom line up front, and then kind of we'll work our way through thinking about suicide and suicide care, and then come back to these again at the end. So kind of what are the reasons to do things in person? Well, I mean, what people usually think of when it comes to suicidal patients, and what everybody thought absolutely had to be the case prior to the pandemic, was that you needed to see suicidal patients in person because of the physical access to the patient if they need to be transported to a higher level of care. I've always sort of felt a little bit sideways about that, given not many of us actually tackle our patients. Or would literally stop them. But that does come up, and I think it's something we all are learning to question a little bit more, providing involuntary care, and what is the advantage of providing involuntary care. And I'm happy to discuss that more at the end. But that certainly has been the dominant reason in suicide care why people felt that you needed to do it in person. You potentially have greater engagement from the patient with fewer distractions than they may be experiencing in a virtual environment. There's often behavioral activation that comes with kind of getting it together to get down and come into your office. And kind of for some people, just getting them to move and go anywhere is really important. Privacy is easier to achieve in a in-person environment, and crisis response planning is more straightforward. This is often done in collaboration with the person. You can sit next to each other, work it out together, seeing the same screen, having something, walk to a copier, hand something to somebody, and they leave, right? There's lots of complexities around that that are easier in person. On the other hand, there's advantages of telehealth. One is in around suicide care, is you can observe the patient's living situation, and it's an opportunity for sort of visual inspection around lethal means counseling. So I've had patients where, I'm asking them to pour out alcohol or get rid of sharps or whatever, and you can actually do that live now, or kind of help them sort of take action in a sort of joint way. For instance, if they're going to have somebody else in their family take their firearm, you can watch the whole thing happen if you invite that other person there, and all of those sorts of things. So that can be an advantage in some circumstances. Um, you can facilitate engagement with the patient's family more easily if they're at home with their family. We saw this particularly during the pandemic. People are not always there the way they were at the beginning, but there's still an opportunity there rather than they're here by themselves, you're scheduling at another time, etc. There's evidence of higher attendance to treatment, and much faster ability to reschedule. So I think that treatment attendance is important, and that it has certainly been a force behind supporting telehealth at the university as much as we can do. And of course, the reason we ever got into this in the first place, less chance of spreading respiratory illness, which may not be very important at this time of year in the Northern Hemisphere, but something that has, I think, kept a lot of people um, in sort of more concern because, being in a small room for 50 minutes together, has implications. Um, and we have never really kind of got the HVAC thing figured out. So, okay, so let's pivot to, whoops, I'm gonna close this little window here. Okay. Uh, to talking kind of through suicide risk assessment and treatment more generally. And then we'll come back to sort of what does it mean in a telehealth environment. So I'll talk a little bit about risk screening and assessment, and this kind of concepts of management and treatment that we think of as the suicide care pathway. Talk a little bit about telehealth and some technology supports and apps that might help your work. And then I'm happy to have a discussion at the end. I'll try to move quickly through the slides so we have some time. I want to acknowledge the contribution of Jeff Sung. He's a psychiatrist I work with closely at the Center for Suicide Prevention and Recovery, as well as the Suicide Care Research Center. And many of the slides and perspectives that you're seeing here are work we developed together, or things he's developed on his own. So one of the things that we think about is this idea of a suicide care pathway. This has been something that's really developed over the sort of 2010s. So some of you have heard of zero suicide. This is a model that's looking at sort of all of the different elements of suicide care across the health system. We're seeing this idea of a pathway and steps that need to be done in our Joint Commission work, and as well as the recommendations for suicide prevention. The CPGs are the VA and Department of Defense joint recommendations or clinical practice guidelines for suicide prevention that also think in terms of these steps in the process. And what we're seeing in initial work is that improving this pathway across a health system is associated with improved outcomes across the population. Some recent data from Kaiser Permanente, Washington, demonstrating that implementing these integrated systems within the health record and sort of structure of the clinical team is showing reductions in suicide attempts. So what do we mean by this pathway? So what we're talking about is starting with identifying suicide risk, often done with a PHQ-9 or an ASQ. This has become a more standard element of care. Oh, and the idea is that we want to have some vehicle for knowing if our patient is experiencing suicidal thoughts, suicidal intent, or other kinds of risk factors. That the idea is that screening is just noticing that the risk exists. Then you have to assess what actually is going on with the risk and come up with a formulation. Like, what do you think is putting all the pieces together here? And there's sort of this concrete kind of risk level kind of work. I'm going to speak to that a little bit. And then there's also trying to understand what's really driving the person's suicidality that will allow you to make the biggest change as quickly as possible. Then you want to intervene, right? So we divide intervention between management or the short-term crisis survival versus treatment, which is how you're going to get the person to be able to manage suicidal thoughts themselves, but also recover and have a life that's worth living. What we hope is not going to happen is people will go on kind of managing this chronic condition of suicidality. What you see, most often, and we see frequently in psychotherapy trials, is this is something that can be resolved. People can move beyond it, step away from it. Um, a metaphor I often think of is, as if you kind of broke your leg and maybe you'd have to have some surgery to get your leg braced and you'd have, be unable to walk for a period of time. But then 6 weeks, 8 weeks from now, you're kind of stepping together. And a year from now, this is totally in the rearview mirror. But we do want to always be attending to and thinking about follow-up and do we need to kind of how are we going to maintain a risk assessment or detection over time? And what are we going to do if it reappears? This is what we mean by the pathway. For screening, there's some pretty standardized screening. A lot of people use the Columbia Suicide Severity Rating Scale screener or the full length interview, although mostly I see people using the screener these days. And these are often linked to specific steps. So this is an example from some years ago at the Harborview ED where you have these specific direction of what to do with different levels of risk. Then you're going to want to think about doing standardized risk assessment. I tend to spend a little less time on this issue in particular because it's often dictated by the health entity that you're in, how this is happening, and there's no particular evidence of one versus another measure. In fact, if you look across a number of different measures, so we have had three self-report measures, two interviews that were done in a very large study of active duty service members. And they kind of randomized people to receive each of these different measures. And what you can see is that we have this row one here, 45% of people just said no on everything. And row two, we have another 20% who said yes on everything. And then we have this remaining 35% who either came up as at risk or not in terms of their suicidal behavior based on how they were asked. So it's just important to recognize that putting a lot of attention into which assessment you're picking it may not pay off. This study also found that whether you used one of these quick self-report tools, the SBQRs, I think a 6-item tool, versus full-length interviews, the ability to predict a suicide attempt at 90 days was like a 1% improvement in your ability to predict a suicide attempt, and it didn't matter which measure you used. So, I think that, doing something to understand what's happening with the risk is helpful. Using a standardized assessment is an expectation, or if not standardized, evidence-based at least, assessment is sort of an expectation of something like Joint Commission. Um, and you sort of want to kind of take it with a grain of salt. In fact, if you look at other countries, so this is a combination of experts from Australia and the United Kingdom, they're questioning whether we should do any kind of stratification of patients at all according to suicide risk, because the ability to predict risk is really, really low. Now, part of that is that this is just a phenomenon of when you try to predict a really low base rate um, behavior, that's often hard to do. But we also don't have something like a hemoglobin A1C or a blood pressure medicine measurement, or we just don't have an infection culture. Like there are things in medicine that allow you to have a pretty definitive measure, and there's nothing, as I said, in suicide prevention that achieves that. And so expecting people to stratify patients and act accordingly is a US idea. It is not universally shared. Um, and instead, there's more general principles of how to approach patients and how to respond to patients that are that don't have to do with are you high, are you medium, are you low. That being said, risk stratification has been endorsed by the Joint Commission, and there we go. Other things to think about in your assessment is that you may want to use other measures that address cultural risk. So the cultural assessment of risk for suicide, or the CARS scale, is a self-report scale that allows you to measure a number of different dimensions that are more culturally specific. Um, Example items are things like there's conflict in the family. I do, or that's scored in reverse. I have an absence of community, issues around sexual minority stress, um, issues of acculturative stress, uh, non sort of specific minority stress, sort of discrimination, microaggressions, specific idioms of distress, things that may show up and manifest um, as distress in different cultures compared to a typically American kind of European white model, different ways that people think about actions of suicide, and what the cultural sanctions might be in your culture that actually are preventative. Related to that, there's also ways of thinking about strength-based approaches and thinking more about increasing protective factors as opposed to decreasing risk factors. So thinking about how much can you have see how much does somebody believe they can actually have some efficacy over their own life problems? How much do their cultural and spiritual beliefs help them to stay alive? Other kinds of uh, you know, ways in which you sort of feel are essentially seen by your community. And so these are also measures that you may want to administer even in a general population, because they may be getting at things that you wouldn't otherwise. Now, I made this whole point about how risk stratification and how we generally don't do it in lots of parts of the world, but here in the US, it is something that people are expected to do. So this is essentially formulating risk. Um, if you do the Columbia, which many people do, you're going to get that high, medium, and low with the, what is it, green, yellow, red. The concern I have with that is that the threshold for hitting red is quite low. And so for many people, we'd be sending many people to the ED very early, because that kind of is the recommendation, getting a higher level of care. And it really is conflating and confusing the risk that they have in your telehealth visit today with their risk overall. So I vastly, vastly prefer the model that is recommended by the VA and the DoD clinical practice guidelines as part of the therapeutic risk management that they endorse. You can see some links to this here. So what they recommend is separating acute risk for suicide and chronic risk for suicide. And my experience is even though there are two ratings that I'm making, I can do this much faster than a single rating that where I'm trying to sort of balance acute and chronic risk. And as somebody who does a lot of dialectical behavior therapy with people with fairly chronic suicidality, being able to tease apart what's their risk today, which might be quite low, versus what's their risk overall, I think is a very helpful distinction. So if you think about acute risk, we're talking about, high risk is you're going to mobilize them into an emergency room or you're going to bring in outside forces. This is above and beyond what you're going to handle in an outpatient setting. That's kind of this idea of high acute risk, low acute risk. They may have some suicidal ideation, but they don't have any kind of planning or intent. And there's considerable confidence that the person has their ability to be safe and that there's not a reason to think they're going to take any action. And then we have our intermediate situation, which is where we often in behavioral health are sitting where we have patients who are thinking about suicide. They don't have any plan to do anything today. They can take action on their own behalf to prevent themselves from committing suicide today, but we definitely are going to want to be keeping an eye on them and potentially increasing the frequency of our contact if you're a psychiatrist, for instance, seeing somebody, every month or two. By contrast, there's the idea of chronic risk. So in chronic risk, we're talking about you've got ongoing suicidal ideation, and that's paired with some risk factors that are going to kind of put the person at risk. And for many of us working in community mental health, we've got a lot of folks with high chronic risk because there are a lot of risk factors that are going on. And the idea here is that the person is sort of, people think of it as like, uh, that you have this kind of chronic risk, and then therefore it doesn't take that much to kind of trigger you into active suicidality because you're kind of simmering below the surface. And so because of that, you want to make sure you've got good plans in place of what they can do during an emergency. You have a way of thinking about how you can continue to screen for risk and that they've got some ways of coping on their own as well. Now, you see often that the risk is mitigated by a lot of protective factors. So if what you've got is you've got high chronic risk, but there's really good evidence of protective factors. The person has evidence, they've demonstrated that they have good coping skills. Then we would expect that there is a safety plan. We're going to kind of get them organized around how to mobilize in the face of warning signs. But we're probably not going to need to do the same level of monitoring with them. And then we have people with low chronic risk. So you have somebody who, uh, we see this with students who, in their freshman year, they were always super successful in high school. They come to college, suddenly it's immensely harder. They're struggling with their courses. They struggling to make friends. They finally get, some friends together, and then there's rejection, and then there's an F on a test, and then they make a suicide attempt, or they're acutely thinking about suicide. So that may be somebody with really high acute risk, but there's no evidence of an ongoing process. So hopefully you can see that by separating this out, most people can very quickly classify most of their patients this way. And there's a lot of guidance available through the VA the VA's put really a lot of attention into being able to help people to make these distinctions. So I recommend all of this is free. Okay, so let's say we've identified that somebody does have suicide risk. We then think about the distinction between management and whoops, um, management and treatment. So the idea here is that what we want is a collaborative process where the clinician and the client can be like thinking together about the suicide risk and coming up with some short-term strategies to help the client sort of survive those crises or those dark moments. But it is also the case and needs to be acknowledged that there's a lot of coercive care that comes up when a clinician is concerned for a patient. And so even though it's optimally collaborative, it isn't going to necessarily be collaborative. And it may be doing a lot of things that, because of reasons of how your agency decides to do things or what resources are available in your community, there may be things that are going to mean this is a very uncollaborative process. And I think it's really important to remember this as distinct from actually treating and resolving the suicide risk in two ways. One, like this is like a safety plan, for instance, is going to be an important element of this. But a safety plan is designed to help you understand what your risk is, understand that risk comes and goes and will pass, and to give you specific things to do at that time. It doesn't do anything to address the underlying issues that drive a person towards suicidality. So you don't want to think about that as actually treating the problem. I'll come around to what treatment looks like. So the idea here, if what we really want to see happen with suicide care, this is a set of principles that were developed by experts in the psychotherapeutic care of highly suicidal patients. And the idea here is that you're focused on creating a relationship that it maximizes collaboration, that maximizes an understanding of the patient's story and the patient coming from a place of such mental pain or anguish that they may have very little self-respect. And all of this means they're going to be not very robust to having sort of an interrogation come at them. And that often results in patients sort of retreating, emotionally distancing themselves from the clinician, and a lot of times when we're interviewing people with lived experience, they are reporting that after kind of going through these sort of more interrogative kinds of, do you have intent, do you have plan, etc. interactions, they feel demoralized about mental health care. They're afraid of the potential consequences of answering yes, and will just generally just stop telling people that they're suicidal, right? So we're really trying to engender a very different kind of relationship with the patient, because if they leave, if they don't see you, then you're not providing them very much help. And whatever risk you were trying to manage, like their lethal means or trying to engage family, etc., none of that's happening if they don't come and see you, because you're not planning any of that. They've just sort of withdrawn and disappeared. So we want to kind of lean into the treatment side of this, right? We want to understand what is driving the person towards suicide. We think a lot about drivers. What is driving the person to feel that they have to end their life? And what you want to do is have this collaborative relationship where you and the patient can examine this together, and that over time, the clinician can be stepping back, becoming more of a collaborative, consultative kind of role as the client learns to recognize and manage their own risk over time. Um, and the goal is that the client is able to understand and reduce the risk on their own and they recover. They develop what in DBT we would call a life worth living. So there wouldn't be any reason for them to want to kill themselves anymore. And you can see this is sort of mimicked in something like a safety plan. If you do a full safety plan intervention, and at the same time, it's asking a lot of a patient to be able to do all of this just in one, just by filling, kind of doing a kind of a safety plan form. So you're going to want to get the a good understanding of what are the kind of underlying drivers. The kind of drivers that people often think about are things like depression, financial problems, relationship problems, homelessness. Some of these are what we think of as kind of indirect drivers of suicidality. And the reason we say that is that the majority of people with these sorts of problems are not suicidal. So that it's really hard to sort of uniquely describe suicidality on the basis of this. And many people will continue to have these problems even if you can resolve their suicidality. So, other things that would be kind of drivers to think about either on the risk or protective side that kind of go in this category also are things like sort of how acculturated the person is, kind of history of historical trauma, different kinds of microaggressions and other minority stresses that they're dealing with. And on the flip side, sort of protectively, kind of how much is the family unit driving what's going on for them that kind of helps them to sort of stay alive for other people, or perhaps they're involved in religion, in a religious community or a spiritual community that helps them. Um, and all of these, both the, depression, all of these are probably related to their suicidality. You want to treat them. But there are other things that are kind of uniquely tied to suicidality, um, and evidence-based treatments for suicide focus on them. So things like stress and agitation, intense emotional dysregulation or pain that they're desperate to escape, attentional fixation on suicide, where it's like the aperture of a camera. They've just gotten into this deep tunnel vision where they can't see anything but suicide, a complete lack of social connection, or one of the things that's really unique for towards suicidality is this idea of burdensomeness that I would be more valuable to the people in my life if I were dead more than if I were alive. And when you look at the range of evidence-based treatments, which is beyond what I can cover today, these sorts of drivers are really central to how these interventions, what these interventions focus on and how they help people recover. If you are, I'm going to kind of move into some practical things right now. If I just wanted to call out that we have a number of other training resources. So if you'd like further resources on any of these sort of screening and assessment, lethal means, cultural issues, some of these interventions like caring contacts, you can find that on our website as well. So, what could you just do practically? Maybe you don't know a full evidence-based practice specific for suicide care. Maybe you don't have the capacity to do that in your setting. What I really encourage you to do that sort of brings all these pieces together is to center your initial visits with somebody after learning of their suicidality around their client, around your client's story. What is their story of suicidality? And this is something you'll see in all these evidence-based practices, and something you can sort of take from that without having to, kind of know each of these practices. And what you find, and I see all the time in my research, is suicidal patients who, because we have all of these questions and kind of interviews and structures that we use, that patients will say, I don't get to tell my story, or when I do this and ask the person to tell their story, they will say, I just came from an inpatient unit and I never got the chance to do this. So this is something that where you can learn a lot about those factors that you can then move in and do something about. So, essentially part of this principle of the story is it's not just an assessment. It's that with this tunnel vision, the patient is so caught up in all the trees of misery around them that they just have totally lost track of the forest. And as this quote from John Dewey's, we do not learn from experience, we learn from reflecting on experience. This gives an opportunity for reflection for the patient that allows them in the telling of their story, they're also reflecting on that, which helps them to reduce their risk in and of itself. Like once you sort of see it and you say it out loud, there's a lot of folks who are like, yeah, why did I don't need to do this. Like, why am I doing, like, for some people that in and of itself sort of jumps them out of it. For other people, it can help them see alternatives, that there is other moments along the way in that story they could have done something differently. And it also helps them see that between the story of how they became suicidal or how they made their suicide attempt and when they're here with you today, probably not at their peak of suicidality, they can see that this is something that's temporary and it comes and goes. So, what you're trying to do in centering this story is to remember that many of the questions that we ask are very important to us, but they're not important to the client, like suicide intent or plan or lethal means, things like that. Those are often the questions that the patients find most threatening. Probably not the best place for us to kind of start our to form a connection with the patient. You can get the answers to most of those questions simply from the story, and then ask what you need to know afterwards. So what we often say is, I recommend saying to the patient, let's just start with you telling me the story of how you came to be thinking of suicide or the story of how you made this suicide attempt. Afterward, I'll likely have a few questions, right? And so usually, by the end of it, you have a good sense of how much they're still intending to kill themselves. You have a good understanding of methods. You understand how things came to be. And then you can ask any other questions that you have. But you can also imagine that by telling this story, you figured out a lot of those other drivers that wouldn't have been specific questions, like how much do they feel like a burden on other people? How much are they disconnected? How much are they just so dysregulated they can't think straight? Okay, so this is supposed to be all about telehealth. I'm going to loop back to some specific telehealth, but my part of my big message, and I hope you're picking up on this, is I don't really think it's that different, what we do. I think everything that I just said, I can do on telehealth pretty much the same as I do when I'm in person. There are some things that I think are good practice. So making sure you have good contact information for a person who you're seeing in your office. Do you know where they are? Do you have a phone call number where you can reach them? If you're going to have an ongoing relationship with a patient virtually, making sure you have an emergency contact. Who is it? And then be very, very clear about the conditions under which you would ask um, uh, you would contact this other person, which would be acting against the patient's confidentiality and autonomy. So, like, I really have make it clear to patients that for me, as long as they're working with me, they're willing to try something, they're willing to reach out, they're trying the different coping strategies that I'm suggesting. I'm not seeing myself as needing to go outside of the therapeutic relationship to engage other people. But if they tell me, like, thank you for everything, but I'm not willing to try anything, that's what would get me into into contacting folks outside. Now, on the flip side of this, this is sort of the idea of like who you would contact if you've lost touch with them, for instance. So that's another thing I would say to people is I would reach out to an emergency contact if I've reached out to you and I can't reach you, and I will warn you like that I am going to do that. Like, hey, you've got to get back to me, or I'm going to, if you don't get back to me the next hour, I am going to reach out because I am concerned. This is different than engaging family whenever possible and the patient is willing. So we, or if they're a minor, you may not, it may be regardless of whether the patient is willing. Um, but, I always have that as a value. So you just want to sort of see both sides of that. Um, Now, remember, in the management of all of this, you cannot control their behavior, whether they're in the room with you or not. They can always lie and say they're not having any suicidality, and whether they're with you in the most secure building in the world, they're leaving, right? Like, this is not something we can control. However, we are responsible for having gone through, reasonable steps. To care for our patients. And so what you're responsible for is, did you do what there is to do and not whether the patient responds? The other thing that I highly recommend is that you have an agreement within your agency or your clinic on policies and procedures with regard to suicide risk generally, and suicide risk management, but also specifically on telehealth. So, you know, if you figure this out while nobody's at risk, it's all going to go better. You want to get the right players in the room and just say, how are we handling this? Let's make have a kind of thoughtful discussion about this. Refer to things from this presentation if that's helpful. Um, uh, Oftentimes policy gets set in the middle of a crisis or after a bad outcome. Neither of those are going to lead to good policy. You want to have written policies and procedures that you would be ready to share with an attorney or a reviewer who requests your records. You want to adapt your informed consent documents to clarify what you can and can't do as a provider and as a provider doing telehealth. And then remember, should a bad outcome happen, you want to share both the policies and procedures and the informed consent documents along with the medical records. An attorney will not ask for this, but it is often way more sensible to write this once as a clinic and as a policy that everybody's following than trying to like fill all of your chart notes with all of this information because you're thinking that's all you're sending to the attorney. And there's lots and lots of folks who manage these kind of suicide liability circumstances, who really highlight the value of doing this once, doing it thoughtfully, and then including it in any request for records. Again, you can't control their behavior. All you can do is be responsible for your behavior. And the key here is that, if you have gone through a thoughtful process, if you can document what your thoughtful process is, like your policies and procedures, you might want to include what are the resources that you use to generate these policies and procedures, who were the people who were involved in them, so that there's a good justification for the decisions, because that's just the nature of liability, is that it's really based on what would a reasonable clinician do. So the more you base what you're doing on multiple reasonable clinicians, the lower the chance of liability risk. There are a number of telehealth options. This was all very new. I think 5 years ago when we were first dealing with this in the pandemic. So I don't think it's as critical. A lot of people have pivoted to apps for a number of different reasons now. There are apps that are specific to safety planning, just calling that out. Um, there are apps specific to coping skills. I'm not particularly recommending any one in particular because they keep coming and going, and any attempt I have to try to track them, they, even the websites that are guides for these things keeps coming and going. That's just the nature of tech. Um, there are a lot of free resources at the VA. Like I said, the MyRec has a lot of resources, and there are quite a number of different apps. These are examples of different apps. They're all free because they're developed by the government that you can use alongside your care. So if we just come back to I'll just click through these, come back to kind of our core ideas here, right? That there remain these advantages of in-person over telehealth, but these telehealth advantages are there. And hopefully now that I've kind of described um, how the process works, you could see that probably there isn't that much difference in the care that we would want to provide, whether we're in person or telehealth. Um, and with that, we'll switch to some ending material and we'll come back for discussion. I did want to call out that we do an annual training on suicide care that kind of expands what I'm saying out to meet the requirements of the Washington State training, and we can share that link with you if this was interesting and you're kind of interested in going deeper on that. And then Cara, I'll maybe swap it over to this. We can come back to
Yeah.
questions.
So I think that's it. So I don't know, Kate, if you've had a chance to look at the questions. There's quite a few in there. Um, I guess, go ahead.
Yeah, maybe I'll stop share here and
Yeah.
just we can sort of take turns. So I do think that passive suicidal ideation does indicate some risk. So Uh, and if people are refusing to share or deny their suicidality, I think you need to just people are coming to that for a reason. There is some evidence that, uh, failure to disclose or keeping things private is associated with higher risk. So I would probably associate it with higher risk, but I think you have to always balance trying to get the information from them with the flip side of being in a situation where they can continue to come back. The last thing you want is for them to walk away entirely, because then whatever risk you were worried about is continuing, even though you're no longer in the scene. So I think finding a way to continue to assess for risk, but to do so in a way that doesn't, suggest like there's a moral failure if they don't want to answer. I'd probably come back the next week and say, look, I know this is not going to be your favorite question, but can you tell me how you're doing and whether these dark thoughts have come back? How dark has it gotten this week? Has it gotten to the point where you have these kind of thoughts about death again? Something that will maybe not ask in that most standardized wording, I think shows respect to the patient. Um, uh, the PHQ-9 is the standard measure out there, and usually it's item 9. Any indication on item 9, that's what prompts for risk assessment. And somebody was asking the difference between risk identification and assessment. So identification means you have any reason to think that suicide exists, it's at all in their worldview. So they've told you, their family member told you, they pinged on a PHQ-9, any of these things, this would just indicate that risk exists. And assessment would be, what is the risk about? What are the elements? What are the different aspects of the risk that are present or not present. So that's really the difference between those. I know I'm being a little random here. Cara, I don't know if there's any that you were um, maybe I'll just tackle one.
No, probably have room for just one more question, unfortunately.
Sometimes, I think there's sort of question about like, what if they don't have an emergency contact? What if? Again, to me, I think that over time, if you can maintain a relationship with somebody, you will hear something arise in your conversation with them that indicates maybe they could be that person's emergency contact. So I think what we do too much is insist on getting our questions answered instead of maintaining, kind of learning the story and maintaining the connection, which is what I think is going to reduce their risk and protect them over time. And I'll stop there.